Top Med Talk.
Well, hello and welcome to Top Med Talk. I'm Desiree Chappell, Managing Editor of Top Med Talk and Vice President of Clinical Quality for North Star Anesthesia. And I'm joined today by my co-host, Editor-in-Chief of Top Med Talk, Professor of Critical Care and Anesthesia at the University College London, Monty Mythen. Hello, Professor. Good morning.
Hi, Desiree. It's great to be here, we hope, in Dingle with you, live from the Skellig Hotel on the west coast of Ireland.
It's day 3 of EBPOM, Monty, and we are hopefully looking at those beautiful views that are right behind you right now.
Hopefully, we're going to be finishing this whole session off in the room, in the Gallery Suite in the Skellig Hotel in Ireland, live streaming. But if we're not, it's great to be talking to you back home in Louisville, Kentucky, Desiree. But we can only hope and pray.
That's right. We are prepared for anything. That's what we do here on Top Med Talk, the beauty of virtual. So, Monty, it is day 3 of EBPOM Ireland and day 2 of EBPOM Chicago. It's kind of crazy this year. We combined our 2 meetings. It's going well. We've had a lot of great content. But the last day of the conference and on the Top Med Talk stage, it is Medtronic Day. So they have been a gracious sponsor for us throughout the last couple of years through the pandemic and through all the virtual things and really help us get medical education to the world. So thank you for that. And to that point, we get to have some great conversations on the Top Med Talk stage. So nociceptive monitoring, which we've talked a little bit here on Top Med Talk about. So, Monty, I'm going to go ahead and introduce our first guest. We have Anil Hormis, who's a consultant in anesthesia and critical care medicine in Rotherham, that is near Sheffield. And not being from the UK, I hope I got that all right. Anil, we would love to chat with you today about nociceptive monitoring. Thank you so much for joining us.
Thank you so much for having me, Desiree and Monty. It's a pleasure to be here.
Well, Anil, tell us a little bit more about yourself.
Okay, well, thank you very much. So, I have a few roles within the healthcare system. So I work, as you said, as a consultant anaesthetist and a critical care physician. I also work as a consultant major trauma. That's at the Major Trauma Centre in Sheffield. And I work for an air ambulance organisation as well, the Lincolnshire and Nottinghamshire Air Ambulance. And I've spent some time in the Big Smoke in London, working for London's Air Ambulance many years ago for my fellowship. So I kind of, work in hospital and out of hospital all over the place.
So most of the time you got your feet firmly on the ground, excuse the pun there.
And it's occasionally managed to get it up in the air. But,
and it's a real life experiences that we're going to be talking to you about, Anil, I think, with regards to nociception, which we've heard a bit about before. And as we get into it, I think we're going to concentrate on frail elderly patients having shoulder surgery as something to pivot off for the general principles. But Desiree, why don't we go over some basics first, back to you to talk to Anil about the sort of general principles.
Many people, especially here in the US, we don't know much about nociceptive monitoring. So just kind of walk us through what that is, how it works.
Okay, so I think in Europe, we're quite lucky because we've had access to nociceptive monitoring now for the last 3 or 4 years. And certainly I was very fortunate to have a monitor probably for 5 years now, which I've been using in my clinical practice. I think in the States, it's still waiting FDA approval. Fingers crossed we'll be getting it soon. But I was introduced to it by an Israeli company called Medisense. I knew one of the reps who worked for Medisense, and he kind of gave me the opportunity to try it. And it was, dovetailing with some of the work I was looking at with elderly patients and more just to find its use, really. So the way that it works, and certainly we're going to be talking about the NOL index, which is now kind of being marketed in the UK by Medtronic. It's basically a finger probe that looks very much like a pulse oximeter. You attach to the patient's finger, ideally before general anesthesia, to set a baseline. And it takes various measurements to do with skin temperature, pulse pressure variability, temperature, and it has an accelerometer built in. And with the use of artificial intelligence and algorithms, comes out with a value, with the NOL index. And we can use the NOL index during anesthesia to titrate and optimize our opioid doses. As Monty made reference to, we use it combined with processed EEG to kind of control the depth of hypnosis as well. So I kind of talk about this term precision anesthesia, which I think we're kind of moving towards, where we can give patients the anesthetic in the doses that they require on a patient-specific basis, as opposed to us using our experience and our kind of knowledge from beforehand.
Just to clarify, it's NOL, is it? It's NOL?
NOL, yeah, the nociceptive index, yeah.
Great stuff. For those of us who haven't had hands-on yet, that's very intuitive that, giving an anesthetic, there are physiological changes that we're all very familiar with. Is the anesthesia too light? Are they feeling pain? Is it an inflammatory process? Should we give fluid? Should we give drugs? It is rocket science. Now, is this going to bring us closer to the truth or further into a fantasy land?
We all subscribe to things that we kind of believe in, isn't it? And I kind of certainly having used the monitoring for the last sort of 4 or 5 years, kind of have bought into it, really. I think that, I've had some very good experiences. In a similar respect to using processed EEG, it's there to guide you. It's there to kind of give you assurance that you're giving patients adequate analgesia, but also not too much. But I think it's the idea of using it in combination with things that will allow us and give us a bit more assurance that we're doing the right thing for patients.
Because you've covered two of the bases there. We're going to say, well, let's imagine that the pressure's down or the heart rate's up. We can change some things. Let's imagine you've made your null index happy and you're happy with your level of anesthesia depth. There's another area that's uncovered. That's the sort of, do I have enough blood pressure? Do I have enough flow? Do I have enough volume? Are you covering that off too?
The null doesn't necessarily give you access to that kind of information. I mean, it does look at pulse pressure variability, so you can get an idea from the trace, but we're really looking at the level of nociception. I think going back to what you said before, because traditionally we teach our trainees and we all use heart rate, blood pressure as these kind of surrogate markers for nociception. We then rely on our experience bank of this particular operation causing this much pain. But I think now we're getting a little bit more nuanced in what we can do, and certain points of any operation cause a little bit more nociception than other bits. I found pressure, things like closing the abdomen, can cause a huge spike in nociception. Now, you might argue, well, that's not a real big deal to the patient who's having their laparotomy closed, but actually just to have an idea of what the body's interpreting, I think will just all add to our information moving forward.
I think that is so interesting. Being a CRNA myself, a nurse, anesthetist, you do see different times during the surgery that patients respond that you definitely anticipate and other times that you don't anticipate. And so I think that would be a really great tool to have to just confirm, some of those things and give you a little bit more insight there. So when you're using this technology, are there a type of patient population that this is better than others? Are there types of surgeries that are better than others? Walk us through that a little bit.
Yeah, so I've been, using it in various different types of specialties and age range, over the last few years. But as Monty alluded to in the beginning, my sort of real area of kind of expertise and ongoing research is the frail elderly population. We know that these patients, we need to limit the amount of anesthesia we give them, limit the amount of opioids we give them. And what we're trying to prevent is post-operative delirium and post-operative cognitive decline and dysfunction afterwards. So I've really taken this on in a way because, and looking at in shoulder surgery and orthopedic surgery, we're lucky because we can use combined regional techniques as well as general anesthetic techniques, which again is all good. So the nociception monitor can be used for two things. One is can be there to look at the efficacy of your nerve block or your spinal or epidural, and also in combination with general anesthesia, which for the longer cases we need to do, can then allow you to down titrate, propofol if you're using a TIVA-based anesthetic or your volatile agents, along with opiates such as remifentanil plus morphine. So it's a very much more holistic way of looking at patients and patient care.
One of the things that we discuss a lot here on Top Med Talk and in the realm of anesthesia is the use of regional anesthetic techniques. And some of the conversation that we've had is that, the nociceptive monitoring, it might get a little bit boring because if you're using a regional block, technically you shouldn't be. Walk us through that a little bit, because I know for sure we are using a ton more here in the US. And I assume that, the use of local anesthetic and field blocks and things like that are really
you're absolutely right. In the ideal world, you'd just get a very low null reading throughout the whole case, which is kind of what we want. But if I was to walk you through a typical anesthetic for a shoulder case, the patients will obviously have their general anesthesia. We find intubation, which again, we all know is a stimulating process for patients, but actually their null index rises pretty sharply during intubation, despite having high levels of propofol plus or minus remifentanil running at the same time. So that's usually an interesting kind of part of the anesthetic. You do get some increase in the null index whilst you're doing the blocks. And it's certainly while you're, manipulating patients' arms or shoulders, even if they've got fractures. But the two lessons that I've learned, I think, with regional anesthesia is how quickly the block does actually work for analgesia. So again, if I use it for wrist fractures as a good example, usually within 5 minutes, the surgeons, or 5 to 10 minutes, the surgeons can start operating and there'll be no response on the null index. But we know that if a patient was awake, we'd be having to wait quite a bit more time for them to have a completely anesthetized arm. So in combination with general anesthesia, you can be confident that your block is starting to work. By about 30 minutes into the case, the null index will drop. And the range that we look for is 0 to 25 as a consistent, you can be happy that your patient isn't feeling any nociception. And above 25, that's when we want to start thinking about adding additional opiates. And so if you've got a working block, you should have a very low nociception index, usually 0 to 10 for the whole case, and you can be confident.
I just want to throw a rock in the pool for a second. You've so now you've got your depth of you've got the whole normal monitoring set up, whatever. I'm sure we know what that is for most of us. You've got your depth of anesthesia monitoring, and you've tweaked that such that things are just looking perfect from your perspective. You've now given your analgesia because your null index has come up, and that looks perfect. And now you've got a frail elderly person, previously hypertensive, preoperatively, although controlled, diagnosis of hypertension, who's in a head-up sitting position, however you do it. And their mean arterial pressure's 62. And their systolics between 98 and 100. And you give some fluid and nothing happens. What do you do next?
That's a very common scenario, isn't it? So,
yes. Do we get nervous or do you get a coffee?
Recently, early on this year, there was the new standards of monitoring guidelines that have been published by the Association of Anaesthetists, which are a brilliant evolution of the standards in the UK that we use for monitoring. To talk about processed EEG, the big sort of change in the standards this time was that we could be not solely relying on an index value like the BIS number to be looking at. We should be learning how to interpret EEG, learning to interpret the different waveforms that happen under general anesthesia. And for someone like me, who I think on a geek scale of 0 to 10 is probably around about a 6 or a 7, I've got colleagues who really are full 10, probably 11, or some really want to know about the EEG. But, I've got a lot of colleagues who just see a BIS number of 40 and go, oh yeah, that's fine. But the reason to mention that is that there is a lot more that we can do to optimize anesthesia by using waveforms, by using the ability to look at alpha waves. With the latest software in the BIS monitor, we've got density spectral array now, which gives you a really nice way of looking at the power bands and the spectrogram. So the first thing I'd say is that we can really optimize depth of anesthesia in that respect. By doing that, we often find patients have their hemodynamics preserved a lot more than previously, I would argue. The second thing, the combination there is with, using the nociception monitor to kind of optimize the remifentanil. And again, if you've got someone who's, paralyzed, who's intubated, who's got a regional block in, they really don't need very much. And certainly in my practice, the remifentanil is there just to prevent me from having to give too much more muscle relaxant for these long cases, because again, muscle relaxants hanging around, as we know, is not good for patients at the end of surgery. So it's a combination of things, really. But patients do get hypertensive for sure. And, you have to maintain their hemodynamics in the beach chair position, the sitting position for shoulder surgery. The surgeons that I work with do all of their cases like that. So we're paranoid because the critical endpoint that we're trying to prevent is a patient having a stroke, when their blood pressure drops. We do know that we need to keep their mean arterial pressure elevated. The problem is we don't know by how much, whether we should be at 10% of lower than baseline, 20% lower than baseline, or even higher than that. So we are lucky, and I'm lucky in our hospital that we have support from Medtronic to use cerebral oximetry monitoring. So the INVOS machine allows us with NIRS to monitor the oxygen saturations in the frontal lobe. Again, that's an additional monitor, so we've already got 2 or 3 different things going on at the same time. But in this frail population, it is really worthwhile because we can know that their mean pressure needs to be higher, and then we can see at various points in the operations where it drops off. The big one is when we sit them up. So the patients, they're laid flat, they're supine for induction of anesthesia. Their cerebral saturations increase in the beginning because we often have them on 100% oxygen, pre-oxygenating them. The minute we sit them up, we usually see a big fall in their cerebral sats as they just come off a cliff, really. And that's the point where, as the anaesthetist, we need to be monitoring, making sure we know what's going on and intervening at that stage.
We have to be careful what we say here because we're not giving guidance to people, but just between you and me, how low is too low for you? Because, interpreting cerebral sats is not like interpreting your pulse oximeter sats.
Yeah, but that's also affected by patients' previous comorbidity. So patients who've had previous strokes in the past, they might have one side of the brain which has lower oxygen sats from lower blood flow. So again, with all these things, you set a baseline before you put the patient to sleep. They're in a supine position. We put the BIS strip on, the INVOS strip on, get an idea of a baseline. The INVOS machine allows you to set a range of plus or minus 20% where you like them to sit. And then you can see the changes, really. But yeah, I think saying to someone, oh, the sats must be above 55, 65, whatever, it's difficult to do, but you get a good idea of where patients are sitting, but more importantly, how that correlates with blood pressure.
Yeah. And when I started using cerebral oximetry in shoulders, it changed my practice. Before that, once you get reposition somebody and then their blood pressure cuff just keeps rolling and rolling, and you're like, well, is it just because we're positioning? Because we're still doing a lot of weird positioning stuff. And usually it was hypotension, right? And it was just taking forever because you had such a drop in your blood pressure. And then once you put the cerebral oximetry on there, that was your other tool to say, like, you were having issues with blood pressure. And I started, setting our patients up a lot more slowly and being much more conscientious about the elderly patients that we knew would drop out on us. And so I think that it really does. It's just another example of how, adding those additional tools in can make a difference and give you a broader picture.
Previously, I was someone who would keep their end-tidal carbon dioxide a little bit on the lower side. But actually having it on a slightly higher side gives you more cerebral vasodilatation. You can see the changes in oxygen saturations at that stage. The other thing that's quite useful as well is if you do have cases where patients are bleeding, again, it's not particularly common in shoulder surgery, but if you've got proximal humeral fractures or humeral operations, and again, even a small amount of blood loss in these patients can be critical. That again will start to affect cerebral oxygenation, so you can think about whether they need a blood transfusion and various things. So it's all extra information that is feeding into our management of these patients.
One of the hot topics in vogue kind of things here in the US, and I think, internationally, is opioid-free or opioid-sparing techniques. And that is, a lot of times using regional and things like that. When you use this monitor, how does that play a role in that particular space?
Yeah, again, it's additional information, isn't it? Because I think previously we would have said, this operation might have required 10 milligrams of morphine, 20 milligrams of morphine. And we use our experience. We've been doing anesthesia for many, many years. However, this does allow us to change that a little bit. And a very interesting example that I had last year, I was doing an emergency theatre list with two patients, both having emergency laparoscopic cholecystectomies. The first patient was a female patient. She was 50 kilos, having an emergency lap chole. The second patient was 135 kilos, a male patient, having the same operation, same surgeon. And what was fascinating, and this is a bit of a loaded question, so I'll ask the question and tell you the answer, but one of the patients required 6 milligrams intraoperative morphine, and one patient required 15 milligrams of intraoperative morphine, okay? I won't ask you which was which, but interestingly, the 50-kilo lady needed 15 of morphine. And in the PACU, she had another 15 of morphine, whereas the 135-kilo man had 6 milligrams intraoperatively and didn't have anything else in the PACU. And that was one of the case series that really, really fascinated me, because for years we've talked about variants in how patients react to morphine or other opiates. And for me, a lap chole operation was a kind of a minimum of 12 to 15 milligrams of morphine for most people. But now, by using the null monitor, I feel that I can nuance that a little bit more. No doubt that the opioids are potentially being overprescribed in hospitals. The major problem is when patients go home and all of this stuff. So I think if we can contribute to patients not having to have so many in hospital. That's where our expertise lies, I think.
You're a 6 or 7 out of 10, you said, and you've got some colleagues who are 10s and 11s. I'm probably hovering around 10 for various different reasons, with enthusiasm for gizmos.
Yeah,
now,
that's a different question.
I was a clinical director and budget holder, so you can't have any of those devices because you don't have any evidence for them. I know that's not true, but come on, defend that one.
Yeah, I mean, well, that's exactly where I find myself currently at the minute, And I think the biggest way to get around that is obviously to help to contribute to the evidence. Okay, so that's one thing that we're all trying to do, but also getting the MDT involved. So, our surgical colleagues, getting the patients involved, getting families involved. The surgeons that I work with, they are just amazed sometimes with how well patients recover. Not just from my anaesthetic, obviously, but from colleagues as well. Just how much anaesthesia has improved in the last 5 to 10 years. And what we do know is that the frail elderly population are going to become more of a problem. So things that we're looking to do is to examine length of stay, examine, amount of delirium, how much delirium contributes to length of stay, how patients do post-operatively. Are they up and about? For having a shoulder operation or an upper limb operation, they should be mobile the next day for sure, and they should be out of hospital pretty quickly, notwithstanding social reasons. So they're the kind of metrics that I suspect the hospital is interested in. On an anaesthetic department level, different, isn't it? But I still think that all of this feeds in. The cost of these monitors is coming down all the time. The cost of the consumables is coming down all the time. And actually, everything that we can do to improve the patient pathway has got to be a good thing.
Great answer.
Yeah. I was going to ask a question about post-op delirium and the differences that you've seen since using the null monitor and the impact on direct patient outcomes.
With all these things, I can provide you lots of cases where everything went well. I'm also very honest about when things don't go so well. So I think patients who've had the perfect anaesthetic will be up and about and go. The patients who don't, there's often multifactorial reasons why they haven't done so well. We've definitely noticed a decrease in post-op delirium. Okay, we definitely have noticed a decrease in kind of opiate use afterwards. We are a hospital that use a lot of regional techniques. So even for hip replacements, knee replacements, or shoulder cases, upper limb cases, people get blocks. So that, I suspect, is contributing as well. But if we were to look at our remifentanil usage, morphine usage within cases, they will be a lot lower, and they will contribute to patients' post-op delirium improvements afterwards, for sure.
All right. As we wrap here, Anil, tell me about that aha moment that you had when you started using this technology and you thought, this could really make a difference for my patients. Because that's, we talk a lot about change management and how we get people to use new technology. For those people who sit more at the 2 to 3 range on geeking out in technology adoption. So what was it that really kind of did it for you that you said, this is a piece of technology that I should be using in surgery?
For me, there was one particular case about 4 years ago. It was an 88-year-old lady who'd broken a hip, so a neck of femur fracture. She lived alone at home beforehand. She slipped on the ice, broke her hip. Now, this lady was in hospital for 3 or 4 days and she developed a chest infection. She was probably brewing one before she came into hospital. And she was declined anesthesia by 3 of my colleagues just because of a pneumonia. They just said, look, she's unlikely to survive. So the surgeon that I work with on a Wednesday said, look, if we don't anesthetize this lady, she's definitely going to die. But I think, and Kevin said, if you use your fancy machines, I'm sure we can do something for this lady. We took her to theatre because we felt she was preoperatively pretty good. She had an epidural placed. She had a general anaesthetic. I used processed EEG, so the BIS, and nociception monitoring. I was able to run her at a ridiculously low, an end tidal of isoflurane of 0.3, I think I used for her. She had a couple of nanograms per mil of remifentanil and an epidural running at 2 mils an hour with the pyrocaine and diamorphine. Sorry, she had a revision hip surgery. That was what she'd got, a periprosthetic fracture. Sorry. She had 6 hours of surgery. She woke up completely awake and alert. And so bizarrely, before we'd gone off to sleep, I was explaining to my ODP colleague that I had to go and watch my son playing rugby in the evening after work. She woke up on the HDU and said, did your son win the rugby match? And for me, it was a real aha moment because she was aware of any of that. We were talking freely whilst we were getting ready for the case. I knew that I'd anesthetized her with a very, very low amount of anesthetic. Thankfully, she didn't remember anything about the operation, but to have that kind of clarity of thought and ability to talk straight after the case was incredible. I think that's when I realized that actually the combination of all of this stuff is where we need to be going, optimizing, titrating, not just anesthesia, but also analgesia. That's got to be the way forward.
And then if I can just add, because I was on our, let's call it SICU because it translates more around the world, PACU, extended recovery, over the weekend, talking to the nurses and the trainees. And man, do they see the difference between the patients, same procedure, same, risk profile. As you described, the way that some people are brought back to the unit, they probably don't need to be there wide awake, ready to rock and roll. And other people, it's just a very different scenario. So well done you and everyone who's trying to get this done. My departing question, which don't have to go into detail, Anil, is this is getting very, very challenging to balance all those monitors and all the interventions. Are you ready to let the computers help? Closed loops and stuff. Are you? I mean, under your control, fly by wire, autopilot. You ready? You up for it?
I would be, actually. I definitely think with propofol, I think there's probably some mileage in that. I've not had the chance to see any of the kind of devices that are out at the minute. I've seen them in lectures, but I think so. I think, we're getting there.
Great to talk to you, Desiree. Thank you.
Yeah, it is. I love precision anesthesia. Hopefully we can talk to you again and hear more about your experience and the different technologies that you're using. It's absolutely fantastic.
I'd love to. Thank you very much for the chance to talk to you both today. It's been fabulous.
Anil, I think you're speaking at one of the Association of Anaesthetists great meetings coming up soon. You should give that a plug if you know a bit more.
So the Association of Anaesthetists annual congress is running on the 23rd, 24th of September. I'm doing a lecture. It's a sponsored lecture by Medtronic, but talking about exactly what we've talked about today, the use of processed EEG, nociception monitoring and cerebral oximetry to anaesthetize high-risk patients. So
23rd and 24th of September, because this is a pre-record.
If you're registered, you can see it online.
Well, Anil, thank you. And thanks for everyone watching and listening today. Wherever you are in the world, we appreciate you joining in the conversation and look forward to more conversations on the Top Med Talk stage today. You can visit our schedule, the agenda, and I'll let you know all the other great conversations and fantastic content on the main stage as well. So have a wonderful day. Anil, thank you so much. And we will see everyone soon. Cheers.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.